Okay, chapter 11, drugs for pain management. This will be a very brief video in regards to the drugs for pain management. Okay, um, so here we go. Okay, so the definition of pain is defined by the International Association of Study of Pain as an unpleasant sensation or emotion that produces or might produce tissue damage. So, as a memory jogger, you want to know that pain is whatever the patient says it is, occurring whenever the patient says it actually occurs, and at the intensity, whatever your patient states. So, you're going to have your different parts of pain. The first one you want to know is about the smallest amount of tissue damage that makes a person aware of having pain is their pain threshold. And everybody has a different pain threshold. They feel pain in a certain way. There's acute pain, which is related to an injury or like surgery, recent surgery, or some type of trauma. Um, or some type of trauma. Then you have chronic pain, and chronic pain is basically, it's a pain that continues beyond the expected time frame of an acute injury process. So just as a memory jogger, just make sure you actually look at your memory joggers. It's in your book. And it basically goes over just what I said in regards to what acute pain is and also what chronic pain is. And you have your classifications of pain, which is going to fall into the acute category, chronic, continuous, intermittent, um, no, nociceptive, visceral, neuropathic, and also cancer pain. And your book, Table 11-1, gives you examples for each one. This chart here basically shows you how pain is perceived through, you know, um, it's through the nervous system. It's a sensory pathway of the pain perception. Like for example, a person is aware of damage to the toe and perceives the pain in the toe. You also have something what we call like a referred pain, or you can feel it in one area, it happens in one area, it refers to the next. So those are different areas where you can actually see pain. But today we want to look at how do we manage pain management. What do we use to manage pain? Uh, and when you're doing the assessment of your patient, they're giving you all the information, and based on the information that the patient gives you, this is how the doctor can relay on what type of pain medication that your patient should be able to receive that time. And they come in different categories, such as you see here. And you have the opioids, which can be natural from opium. You have the synthetic, man-made. And the stronger the pain, the more higher the dose or the more potent, you know, the medication management would be. And as a nurse, one of the ways when you're doing your assessment is by actually looking at pain charts or looking at, when you're giving pain medicine on the MAR, they may have like a chart there that can show you from 0 to 5 how the pain looks from, being worse and so forth. There's another pain scale you can ask the patient on 0 to 10, how is your pain category? So they have different types of charts and ways to actually do this. And children and infants who are not really able to express their pain only by maybe their leg movement, their facial movement, their activities, the cries, the consolability, they have pain charts for that also. So when you do begin to manage the pain, you can go by the charts and the doctor can know which way to go about prescribing these pains. Another thing you have in your book is the memory jogger, the 4 main categories of drugs used for pain. So that's going to fall under your opioid agonist, your opioid agonist antagonist, your non-opioid centrally acting analgesics, and your miscellaneous analgesics. So let's take a look at those. So basically your analgesics, you have a wide range of drugs used for those. And some of these drugs are actual analgesics, which have a specific effect, purpose on the relief of pain. So you have your opioid agonist analgesics, which those are going to be your forms of your narcotics. And many drugs used for managing, those that are for severe pain are going to fall under the opioid category. Table 11 2 actually shows you some, um, equal, equal analgesic adult dosages of common opioid agonists and also opioid agonists, um, ag- ag- agonists, antagonists, opioid, that category. So let's see. Okay, let me go back to here. So under that, you have your different categories of drugs. So your opioid agonists, you're going to see those drugs such as the codeine, the morphines, the fentanyl, like when they come in patch forms. So you have those. And under the opioid agonists, you have drugs such as, which are newer generation, like a newer set of drugs. And those are your, like, for example, your statos. So you have those. In table 11.3, it's going to show you the different dosage and nursing implications of the common opioid agonists. And it's going to give you a lot of nursing implications that fall under that. So make sure you look at those because it's going to be really, really important because that group of drugs, the nursing implications are all basically the same. Okay. And as a memory jogger, any type of strong opioid agonist analgesics such as the hydromorphine and the fentanyl is going to require less drug. Lower dosage are going to be given less often. So those are things you want to let your patient know, like if they're going to be on those drugs, if it's every 6 hours, it's every 6 hours. Nothing more, nothing less. Because and some patients may have to be given that plus another drug, like intermittent drug in between, just to work on that pain piece. But if it's like a fentanyl patch, that's going to be placed on maybe and probably taken off in like 12 hours or so, or 24 hours. So those are different things you want to basically remember when it comes to the memory jogger. Another memory jogger you have is the strong opioid agonist analgesics. It's going to include the morphines, the hydromorphines, and the oxymorphines, and the fentanyl patch. And these drugs also, are very strong. And a lot of times you see them as street drugs too, that patients may be selling on the street, like taking the fentanyl patches and so forth. But you'll learn that more, I think, when we get into mental health and we're talking about the different drugs and the usage of the street drugs and everything else there. What are going to be your uses for these opioid agonists? And they are used to manage moderate to severe pain and chronic pain and so forth. And they may be used preoperatively before the surgery, and um, and also to treat pain from injuries like other diseases. For example, the codeine, they can be used for cough medicine. It could be used, some medicines are used for post-op pain and also for labor. But you have some other ones like for example, like the fentanyl patch. That's a released transdermal patch that's usually used. And of course, you're going to have your expected side effects, and And the two most common side effects of the opioids are going to be the sleepiness, the sedation, and also constipation. Other expected reactions to opioid agonists would be bradycardia, which would be a slower heartbeat or hypertension. So you're going to have all these different expected side effects of drugs, and some adverse reactions also that you will have, which will include bradycardia, respiratory depression, So again, you want to make sure you know those and make a list of, when you're doing that, like in regards to the adverse reaction on those type of opioids that fall under the category, again, the codeines and, morphines and so forth. Top tip safety, serious adverse reactions and symptoms of overdose for opioid agonists and analgesics that require immediate medical attention are respiratory of 8 or less per minute, low blood pressure, excessive sedation or coma, below normal body temperature. So you have all of those. And you always want to take into consideration, especially if you're working in long-term care, the older adults are more likely to have some degree of liver and also kidney impairment that reduces the ability to metabolize these drugs. Okay? Tolerance and dependence and addiction. You're going to see a lot of this in your patients who now, because the population is different, especially in the long-term care facility, it's not just the elderly anymore. You're going to have a lot of those that come in who are young people, homeless people, people who are dependent on these drugs because they probably have an injury or something, and they started off with a minor injury and they continue to use these drugs. And then even normal people like the housewives who take probably some type of opioid for pain. They probably started off with back pain or something, and they became extremely dependent on these drugs. So therefore, you have the word called tolerance. The same amount of drug produces a decreased effect over time, how they tolerate the drug. So you're going to have the word called dependence, a state in which the body will show withdrawal symptoms if the drug is stopped or reduced. Then there's addiction. So dependence and tolerance are different from addiction because addiction is the uncontrolled need to actually have and use the drug for any, like a non-medical reason at that point. And that's more like a really psychological dependency on that type of medication. Um, And um, so, so again, your top safety tip, again, make sure you look at all of those. And when it comes to pediatric considerations, children experience pain the same way as adults, but young children may have difficulty communicating. So therefore, you want to make sure you're using that pain assessment scale when you're actually, excuse me, assessing the child. So when you're doing your whole assessment, the patient comes in, and you're doing the assessment before a patient can be effectively helped with any type of pain relief is very important to determine the cause of the pain and the whole intensity. So therefore, you want to make sure you use those pain charts. Just don't have to write anything down. Tell a doctor, well, the person says she used opioids in the past and she just what works best. You want to really still assess the pain. You want to really, really, basically, you want to continue to look at that. Now you have the opioid agonist slash anti-agonist analgesics. Okay, and those work. Just those table 11 for. It shows you that most of this category of drugs block the mu receptors and change the perception of pain by agonizing what they call the kappa receptors. The buprenorphine is a partial mu agonist. There's a lot of words there. But you do have your category of drugs that fall under that. And the opioid, in this category of drugs, you'll see the pentazocines, the nalbupines, the butyl-phenols, and the buprenorphines. And those are all your generic names. Sorry, can't pronounce them, but these are much newer generation of medications. And they're all going to have the same nursing implications for those. And the greatest use of the drugs under this category is the relief of mild to moderate pain versus the other ones they are more for like more severe pains. And of course, they're going to have this expected side effects, which is your common mild side effects are similar to those for morphine. And that's going to include the sedation, the constipation, and also the constricted pupils. When you look at the adverse reactions, a higher dose of these drugs are associated with nightmares and also hallucinations. So the opioid, this category of drugs, have serious cardiac reactions, and also, it excites the cardiac system. It can make the heart work a lot harder, which is going to cause elevation in blood pressure. Okay, so when you're doing your nursing assessment, you want to assess the patient's pain the same way as you would for any other opioid. You want to ask the patient whether he or she has ever taken any of these specific drugs and if they had any type of problems when they were taking it. Also ask what other over-the-counter and prescribed drugs the patients are taking within the past 24 hours, okay? You have your non-opioid centrally acting analgesics, and those are your two common drugs. You will see your clonidines and your tramadols. And the clonidines and tramadols have completely different mechanisms of action for pain relief. The clonidine is more like an antihypertensive drug, most commonly used to lower the blood pressure, and it works for pain management by binding a specific, receptor. Um, so, but all in all, it has the use for the clonidine is approved for more like for severe pain, like often cancer pain, the doctor probably prescribe it for that. And it is given as a continuous epidural infusion when that medication is given. It's not a controlled substance, and it is considered to have no potential or any type of addiction or abuse effect. For the expected side effects, clonidine dilates the blood vessels, which can lead to a severe hypertension, and it should not be used in patients who have low blood pressure. And tramadol itself has a mild side effect of sedation, dizziness, dry mouth, and also constipation. Okay. And one of the adverse effects in regards to the tramadol, it can induce seizures and should not be used in patients who have epilepsy or any type of other neurological conditions. When it comes to the clonidine with the drug interactions, um, you know, because it is given by epidural, it has no direct drug interaction, but however, if a patient also takes another drug for blood pressure management, even epidural clonidine can make hypotension worse. Tramadol has a CNS and brain effects, therefore the sedating and other CNS effects are made worse with if the patient sets, if they're on alcohol or anti-anxiety drug, any type of barbiturates, okay? But be sure you want to be sure to determine which other drugs the patient also takes. And again, you'll know that once you complete and do your whole nursing assessment on this patient in regards to, um, you know, pain management. Um, and so the next one, so you have your miscellaneous analgesics, which is your Tylenol, acetaminophen, corticosteroids, the NSAIDs such as Motrin, your skeletal muscle relaxants, and also antidepressants and anticonvulsants fall under this category for miscellaneous analgesics. So your Tylenol, so you have your acetaminophen, and that falls under Tylenol, Panadol, and some other common names that you may know. And the action for acetaminophen acts only in the brain to reduce the production of prostaglandins, which is a body chemical that can cause inflammation in other body areas. And so it's used for really mild to moderate pain. As a top tip for safety, acetaminophen has a maximum daily total dose to prevent any type of organ damage, such as the kidney. So you want to make sure tell your patient to make sure they read the label. One of the expected side effects are rare, um, you know, when they're taking it, but you have to make sure they're taking the recommended dose. And the most common side effect will be nausea and also skin rash. And um, when it comes to adverse reactions, um, where am I? One of the problems with Tylenol is because it is available without a prescription. A lot of people believe it has none, but it does. And when it's given at a higher dose, it can be toxic to the liver, to the kidney, and this is why there is a maximum total dose for this drug during every day. Okay, and again, you always want to look at the assessment and your patient family teaching. And the considerations for pediatrics would be an infant or a young child should never receive an adult dose of acetaminophen because of a severe liver toxicity. You also want to teach the patients to read the label on liquid acetaminophen bottles for infants and small children very carefully to assure the correct dose for the child's size and their age and so forth. And teach the patients to call the nearest pharmacy and talk with the pharmacist to ensure that the dose is correct if they are unsure what dose to give. And to continue along with this miscellaneous drugs for pain, as a memory jogger, just remember these are the common miscellaneous drugs and classes for drugs used for pain management. And it's going to include all of these. So you have your corticosteroids. These are drugs with a powerful anti-inflammatory action, and so they use that for that. Then you have your NSAIDs, like your Motrins and your Advils. You have all of that, and these are and all of them are non-opioid analgesics that have a main action of reducing inflammation. When you're looking at the considerations for pediatrics, again, aspirin should never be given to infants or children because of its association with the development of a very serious health problem known as the Reye syndrome. That disorders can lead to mental deficits, coma, and even death. For your skeletal muscle relaxants, um, you know, you have table 11.5. It talks about skeletal muscle relaxants relieve the associated pain with muscle spasms by slowing contractions, signal transmissions in the motor nerves. And you see medications like the Flexeril and the Robaxin. And these also, one of the things that they do is really, once it relaxes, it relaxes like everything. So you want to tell the patient, if they're driving or anything, to like kind of be careful when they're taking these drugs because it has a CNS sort of like effect on the central nervous system. So before giving the first dose of either of these skeletal muscle relaxants, ask whether the patient has a seizure disorder because these drugs lower the seizure threshold, number one. And also you want to instruct the patients who are taking any type of extended release tablets or capsules not to chew it, bite it, or anything to prevent rapid absorption of those. And because these drugs do have a CNS effect, patients should not drink alcohol or take any other CNS suppressants while on a skeletal muscle relaxant because it can really be intensified. Okay. Then you have your antidepressants, and those will fall under your citrulines and your nortriptyline, so you have all of that. And again, it can be used to improve the long-term sense of sadness and so forth and depression, but you know, um, you know, it also, so, it can reduce some of the types of the chronic pain along with it and also cancer pain along with that. So the most common antidepressants used for pain are the Elavils, the Paxils, and the Zoloft. So they use that. Then you have your anticonvulsants, and it seems like anticonvulsants are used for so many things. But your two more common antidepressants used for that, sorry, your two anticonvulsants that you'll see that's usually used for pain management would be your neurotins and also your lyricas. And they work in the brain to help reduce seizures, yes, but they have also found that it reduces neuropathic pain, like nerve pain with tingling or burning, and also migraine headaches. And so they act as, they're really good also for pain management. Okay, thank you.